Welcome back. I hope everybody had a chance to take a quick break. Those were wonderful presentations by Jermaine Alberti, and it was great to have him back at our conference this year. And we want to continue along two lines. First, we're going to have our next speaker, Dr. Paula Dobbs-Wiggins. She is the third awardee this year from Pathways to Promise for being a mental health champion. And she's also our keynote speaker this morning. Dr. Dobbs-Wiggins is an MD and a board-certified psychiatrist and a distinguished fellow of the American Psychiatric Association. She has a private practice specializing in the treatment of adult affective disorders in Dallas, Texas. Dr. Dobbs-Wiggins is also a retired professor of the practice of pastoral care at Perkins School of Theology at Southern Methodist University, having served on the faculty from 1999 through 2019. Throughout her career, she has worked to increase dialogue and collaboration between mental health and religious professionals to promote greater understanding of mental health conditions and decrease the stigma that often results in people not availing themselves of effective treatment. Dr. Dobbs-Wiggins is a native of St. Louis and received her bachelor's degree in biology, cum laude, from Harvard College, and her medical degree from Harvard Medical School. And during her senior year of college, she responded to a call to Christian ministry and was licensed and later ordained by the Elliott Congregational Church in Roxbury, Massachusetts. She is a strong advocate of community service and currently serves as the chairperson of the Board of Managers of Parkland Health and Hospital System in Dallas, Texas. She is a longtime member of the St. Luke Community United Methodist Church, where she serves. Dr. Dobbs-Wiggins, welcome this morning to Pathways to Hope, and thank you for all you do, and congratulations on your award. You will be receiving, as I told Jermaine, it's in the mail. It'll be coming to you. Since we're not meeting in person, we'll have to send it to you. But congratulations and welcome this morning.
Thank you. Thank you very, very much. I am truly honored to be here and to have received this award and welcome the opportunity to share with you a bit of my journey toward in mental health treatment and advocacy. We are at a time that it is really a hopeful time. When it comes to supporting and advocating for mental health, we are indeed in a season of hope. We have come a long way from the time when people only spoke of mental illness in hushed tones, if at all. And one need only turn on the news or pick up a newspaper to see there is greater interest and openness and understanding not only recognize mental illnesses, but also the impact of mental health on all aspects of life. Athletic performance, healthcare delivery, political decision-making. You know, people are now starting to recognize that if they're going to be whole, if they're going to be well, if they're going to operate at their full God-given potential, they must be as concerned about their mental health as they are about their physical health. We are indeed living in a season in which it is also recognized that social determinants, such as educational level, housing availability, healthy food availability, employment status, and economics, have a major import on health, both physical and mental health. And many would say more of an impact on health than even biological issues that may be going on. Because of this, we can indeed have hope that recognizing that there are connections between physical, emotional, spiritual, and social aspects of our lives opens the way for clinicians, faith leaders, politicians, and community leaders to come together and work collaboratively to enact and support programs that can have a significant impact on the overall health and well-being of not only those who live with the challenges of mental illness, but the entire community. This is indeed a season of hope and opportunity, one that we cannot afford to miss. As I reflect on my own journey as a mental health clinician and advocate, I can assure you it has not always been this way. I want to just share some steps along my journey as I have come to be involved in this work in advocacy. When I applied to medical school in the fall of 1977, my application essay was about what I believed to be the interconnections between physical, emotional, and spiritual health, and the importance of addressing issues in all three areas when trying to increase the overall health of individuals. And there were some people who thought this was an interesting thought, but I had many experiences early on that demonstrated that at that time, many people believed that the physical, emotional, and spiritual realms were quite separate. My faith had always been an important part of my life since early childhood, and in college, I elected to take several classes that were jointly offered to undergraduates and divinity school students. And toward the end of the fall semester of my senior year, I did indeed experience a call to ministry. And on December 11th, 1977, just 10 days after I'd received notification of my acceptance to Harvard Medical School, I preached my initial sermon at Elliott Congregational Church. In the Ecclesiastical Council meeting that followed, I shared my thoughts about the interconnections between physical, emotional, and spiritual health. And I was challenged by a member of the council who wanted to know if I felt that healing was primarily a physical or spiritual process, and was disturbed when I responded, both. When he learned that it was my plan to enter medical school in the fall, he withdrew his support of my licensure to become a minister, even though he said I had preached a pretty good sermon. But his feeling was that a person must approach wholeness and health either from a spiritual or a physical perspective. And clearly I had made my choice. Fortunately, he was only one member of the council, and I was indeed licensed that day and later ordained in that same church. When I started clinical rotations, there were challenges there as well. I was often assessed as being a capable clinician with a good fund of knowledge and ability to connect and communicate with patients, but I was entirely too slow. On more than one evaluation form, there were comments that I spent too much time talking with patients about their families, their jobs, their faith practices, rather than just focusing on the medical facts, developing a differential diagnosis and treatment plan, and then moving on. And even in psychiatry rotations, there was some appreciation of learning about the psychosocial aspects of a patient's life, but many felt patients' religious practices were matters to be at the very least interpreted, and in many cases, medicated. When I looked alarmed about these kinds of attitudes, I was asked to think about things. I remember one resident saying to me specifically, "Look, Paula, Christians believe in, talk to, and hear from a God that they can't see. We call that psychosis." These experiences, though disturbing, did not discourage me. Rather, they highlighted for me just how little people understood about disciplines other than their own. The psych resident clearly did not know much about religion. Many clergy have limited understanding of the advances in mental health treatments. And too many internists and surgeons do not regard psychiatry as a real medical specialty. What was needed was greater understanding and collaboration across disciplines with the goal of providing the best care to patients. And this became the guiding principle of my work, both in my private practice and in other opportunities I had to serve this community. Fortunately, I have been able to witness things getting quite a bit better. While serving as the clinical director of Terrell State Hospital, one of my responsibilities was to do clinical consultation on difficult cases. And I remember being asked to consult on a patient who was experiencing psychotic symptoms, some of which were religious, who was refusing to take medications and was felt to have an unhealthy family. The social worker had reported that the family and some church members frequently visited the patient and reported that faith and family were very important to the patient throughout her life. But the treatment team wanted to restrict visitation by her minister and certain family members because they were felt to be counter-therapeutic. They were speaking in tongues, placing oil on her head, and just kind of muttering and seeming to encourage her ongoing psychotic process. Several team members commented that it was often impossible for them to distinguish between her symptoms and what these people said were their usual religious practices. So rather than shutting them out, I suggested that we invite the pastor and family representatives to participate in a special treatment planning meeting in which everyone was asked to listen to understand rather than listen to respond. It was a very interesting process. The minister was able to help the treatment team better understand the patient's religious beliefs. And the very thing that the treatment team had struggled with for weeks, trying to distinguish where the symptoms began and the religious practices ended, the minister was able to do in a matter of seconds. Yes, he said, yes, people speak in tongues and shout and dance in our worship tradition. But there comes a point when everyone is able to sit down and allow me to preach. And for the last several months, she has been unable to do that. Something clearly had changed. The treatment team, on the other side, was able to help the minister to understand the goals of pharmacologic and group therapy. And as a result, both sides gained insight. The minister gained insight into the goals and expectation of pharmacologic and group therapies. The treatment team gained insight into the religious practices of the patient. And the result was the patient began participating in treatment religiously and was soon able to be discharged. As a professor of the practice of pastoral care at Perkins School of Theology, I taught a class, Mental Health Skills for Clergy. Recognizing that a significant number of people experiencing mental health symptoms will first confide in and seek guidance from a religious professional, the class was designed to equip future clergy with the knowledge and insights that would enable them to be a good shepherd to parishioners with mental health concerns. The primary objective of the course was to familiarize students with the most common mental health conditions, available treatment modalities, and know how to effectively make a referral. To ensure that none of my students would wind up with a siloed understanding of mental health concerns, students were introduced to the biopsychosocial cultural formulation of disease. It was well known that you could not pass my class without being able to say and explain the meaning of biopsychosocial cultural. And nothing pleases me more than running into a former student who greets me by saying, biopsychosocial cultural, I still remember. In addition to class lectures, each student was required to do a study of an agency or individual provider of mental health treatment and do a class presentation on the range of services provided, referral requirements, cost of services, how clergy can be supportive of persons receiving services, and volunteer opportunities. Students also had to write a litany of caring or responsive reading that could be used in a service of worship during Mental Illness Awareness Week or Mental Health Month. There was also one class each term that was open to the public. And it was in the form of a symposium entitled Mental Health and Spirituality, Bridging the Gap. I taught that class every year for 21 straight years. And by the grace of God, it never failed to make and was often full with a waiting list. Just two more experiences that I would share. St. Luke Community United Methodist Church, where I have served as an assistant pastor for over 35 years, has always been sensitive to mental health issues and welcoming to persons living with the challenges of mental health conditions. But in August of 2016, after reviewing a church-wide survey of pastoral care needs of the congregation that identified numerous mental health concerns, Pastor Velda Turnley, who will be facilitating a workshop this afternoon for this conference, asked me to chair a mental health task force, which sponsored the first Mental Health Awareness Symposium on October 5th, 2016. The task force has now grown into a full mental health ministry that has sponsored a play that highlighted the multi-generational impact of PTSD, yearly symposiums addressing mental health issues impacting the Dallas community, a monthly 1-hour educational forum with topics ranging from treatment advances to political issues related to mental health, advocacy opportunities, school mental health resources, and a monthly mental health support group for persons experiencing mental health conditions, their families, and community members who seek to come alongside them. The ministry is led by extremely dedicated volunteers, has been able to successfully transition to a virtual format, and is regarded by clergy and mental health professionals in Dallas as a valuable resource to the church and broader community. And finally, as a member of the Board of Managers at Parkland Health since 2013 and chairwoman since 2018, I have become acutely aware of the challenges of providing safe, patient-centered, high-quality health care to all who need it in a county with an extremely large number of uninsured persons, in a state that has not expanded Medicaid, in a county that the Community Health Needs Assessment has identified as having significant healthcare disparities that have been further accentuated by the current COVID pandemic. However, I have also had the opportunity to experience how working collaboratively with city, county, state, and national agencies that impact our service population creates opportunity to make a difference. There's so many examples I could point to, but I will mention only one, the Right Care program. Dallas, like many other urban areas, had historically been challenged by how to most effectively and safely respond to 911 calls regarding persons suspected of experiencing a mental health crisis. RIGHT, which stands for Rapid Integrated Group Healthcare Team, CARE, began as a pilot program funded by a Smart Justice grant supplemented by the Parkland Foundation in 2017 to support the formation of a collaborative response team comprised of a police officer, an EMT, and a master's level social worker, which would respond to such calls in the area of the city that had historically had the most mental health related 911 calls. The team was able to provide on-site assessment and in some cases provide on-site stabilization. Referral to outpatient treatment was also able to be done, referral to available community resources, and when appropriate, transport to the Parkland Psych ED. And only when absolutely necessary and indicated, transport to jail. By the end of the pilot, the program had exceeded all of the initial expectations, decreasing the number of police resources expended to address mental health concerns, and enabling patients to get to the right care. The program was expanded initially to 5 teams, and one of the joys of my work was being able to approve the budget and plan to expand it now to 10 teams. We are indeed in a season of hope. The word hope is commonly understood to mean a wish But I believe we are in a season of hope in the spiritual sense, which is the confident expectation that what is sought will indeed come to pass. I have spiritual hope that if each of us will commit to just three things: one, to continue to educate ourselves and others about mental health conditions and available treatments; two, be quick to recognize and confront stigmatizing attitudes and policies that negatively impact those who live with the challenges of mental illness; and three, be alert to opportunities to work collaboratively across disciplines to enact policies and interventions that will enhance the mental health and well-being of all. If we do those three things, we will continue to move forward in positive ways. I have hope. I hope you do too. Thank you.
Dr. Dobbs-Wiggins, thank you very much for your remarks. You've really characterized a lot of what has gone on in the profession of psychiatry and in ministry over the last 25, 30 years. And it feels like, as you said, we're in a better place. Mm-hmm. And honestly, I think you're a big part of that, for the work that you've done all these years, you do it so well. So thank you. Congratulations again on your award. It's very well deserved, I can assure you. And thank you for being with us this morning.
And thank you, Dr. Dobbs-Wiggins, for your relentless advocacy for our brothers and sisters who are dealing with mental health challenges. And thank you so much for pursuing what you knew in your heart, the way, the truth, and the life. We agree with you 100% that this is a season of hope and opportunity. Thank you so much. Your presence blessed us today. Thank you. And your smile, you have such a beautiful smile.
Thank you. Thank you.